Well, thank you for having me. I'll use this talk to just give a sort of general beginning to end on romosozumab as our sort of new kid on the block, and just kind of start from scratch on that. So it's a kind of a good time to talk about this, as those of us who do this for a living know this drug has been around just a few months more than a year now. And as a 12-month course of therapy, I think many of us are probably just recently seeing most of our first patients who have finished therapy. So my first patient that I put on this drug was a 73-year-old with osteoporosis, 2 low trauma and 2 high trauma vertebral fractures in the past. And she had used oral bisphosphonates for 4 years and had been on holiday for 10 when she showed up in my clinic. And so we opted to start her on romosozumab prior to a plan to get her back on an anti-resorptive. She opted to stop after 10 months due to some perceived side effects, but she had an 11% improvement in bone density at her spine and 4% at her hip. And then my second patient is coincidentally also 73, multiple rib fractures and an L1 fracture was found on VFA. And both of these fractures occurred after she'd been on alendronate for about 3 years. So we switched her directly from the alendronate to romosozumab. And after 12 months of therapy, she had 11.2% gain at the spine and no change at the hip. And those are actually the only 2 I have that have finished therapy, although I have quite a large number in the pipeline. So sclerostin and bone mass. So sclerostin is produced mainly by osteocytes, and it's a natural antagonist of Wnt signaling. And Wnt supports the differentiation and maturation of osteoblasts and also inhibits osteoclasts via induction of expression of OPG. So in the absence of Wnt, beta-catenin is phosphorylated by a destruction complex, ubiquitinized, and then degraded. But when Wnt is present, it inhibits the destruction of the complex, and beta-catenin accumulates, moves into the nucleus, and triggers genes involved in bone formation. And it was noticed that mutations that lead to loss of function of sclerostin are associated with higher bone mass, and that is sort of the beginnings of the thought of this as an osteoporosis agent. So the FRAME study from 2016 is sort of the pivotal original large trial upon which the approval of this drug is based. And this was a randomized controlled trial with 3,300 patients on romosozumab and 3,300 patients on placebo. And it included women aged 44 to 90 with T-scores of the hip between -2.5 and -3.5. And those with prior hip fracture or severe or multiple vertebral fractures were excluded. So this group had low bone density, but those with extensive fracture history were not included in this trial. And there were very careful and quite significant washout periods in place for inclusion, notably including depending on the drug and exactly, I mean, it's hard to sum up these washout periods when you read them, but roughly 3 to 5 year washout period for prior bisphosphonate use to be involved in FRAME. And so results of FRAME are kind of pasted here. And so you can see the 12 months of therapy with romosozumab, and this is change in bone density at the spine. So there was a 13.3% gain in bone density at the spine in the 12 months on treatment. And similarly, a gain, as expected, less of almost 7% at the total hip in those 12 months of treatment. And in terms of fracture risk reduction, as I think probably everyone here knows, a quite dramatic incidence of new vert fractures was had a quite dramatic risk reduction, as indicated here in this bar graph, and also these other fracture outcomes with significance to borderline significance, but a clear trend to a fracture risk reduction in both of these measures. So FRAME was the big important trial there, obviously with women. And we, as we all know, we have a lot less data in osteoporosis in men, but the BRIDGE trial a year later contributed a little in this area. So this was a study of men over the age of 55 with osteoporosis. And 160 men were treated with romosozumab and 80 men with placebo. So a small trial, too small for fracture outcomes, but BMD outcomes looked roughly similar, with 12% gains at the spine, 2.5% gain at the hip after 12 months of romosozumab in these older men with osteoporosis. The third and other most important study to mention when looking at large trials for this drug is the ARCH trial in 2017. And this is unusual in that it's active comparator, so a head-to-head trial between romosozumab and alendronate. And you can see really very similar results in these. There were about 1,700 people in each group, and you can see very similar results in the romosozumab group of 14% gain at the spine in 1 year and 6% gain at the hip in that 1 year. So quite similar to what was seen in FRAME, as compared to much smaller, as would be expected, gains in bone density in the comparator patients who were on alendronate. And despite this being not placebo, so compared to an active and we know effective comparator, it's impressive, I think, to show a statistically significant fracture risk reduction against something that we know is already effective at fracture prevention. And so that is shown in the bar graph here. So significantly better than alendronate in prevention of new vertebral fractures, and similar appearing curves looking at the entire trial, which was the alendronate versus romosozumab, and then alendronate ongoing for the full 48 months. So finding better outcomes with starting the year, doing the first year of romosozumab, and then continuing the alendronate versus alendronate treatment from the get-go. So with those trials, one of the other major things that seemed to be contributed by that last trial was some question marks about safety. And that ended up with the boxed warning that is now on Evenity. So as osteoporosis drug treatments, we got rid of one boxed warning in the last year and acquired another, which is awesome. So this boxed warning is for the potential risk of myocardial infarction, stroke, and cardiovascular death. And I pasted it here so you can see what your patients will see when they open up their box and what they will be reading. And this is based on the various results of these trials, which I listed here. So looking back at these same 3 studies, the FRAME trial, again, the large placebo-controlled trial, serious cardiovascular event rates were not different between the group at 1.1% with placebo and 1.2% with romosozumab. And cardiovascular death was also not different at 0.4% with placebo and 0.5% with romosozumab. But the other 2 much smaller studies, I put the ends in there for reference, is where there was some differences seen raising this question. So in the trial of romosozumab versus alendronate in serious cardiovascular events, it was a 2.5% rate with the romosozumab versus the 1.9% with alendronate. This was not a significant difference. Specifically, cardiac ischemic events with the 0.8% in romosozumab and 0.3% in alendronate, this was a statistically significant difference. And cerebrovascular events, numerically higher, but not statistically significant in romosozumab versus alendronate. Whereas heart failure, non-coronary revascularization, peripheral vascular ischemic events were numerically less common with romosozumab. And then kind of along similar lines, that bridge trial, again, quite tiny in comparison, showed numerically lower rates with placebo than romosozumab, but the ends are very small. And so we're sort of left with not really knowing what to make of this data, how the options are either that the large trial that should have been best designed to find this kind of concern somehow missed it, or a smaller trial found something because by chance, or has been thrown out there as a theory that potentially alendronate as a bisphosphonates might have some protective effects. And there are arguments and hypotheses in all those directions, but until we know more, we have to help our patients navigate this particular warning. And the contraindication is basically recommended not to be used in anyone who had a stroke or myocardial infarction within the past year, and judgment of risk and benefit, and an informed discussion with the patient with those that have risk factors for such. So I think that when I think about osteoporosis, I have a very long horizon. And so I think a lot about sequencing, as many of us do. And so the rest of the talk will be talking about that. And first starting, the question is, okay, if you've chosen to put a patient on romosozumab, what do you do after that? So what's next? And the first thing, and I think we all know this, but the first thing is the answer is not nothing. So like the other drugs that don't have prolonged residence in bone, stopping romosozumab without transitioning to another agent leads to rapid reversal of the gains achieved in bone loss. And this is one of many study examples of that happening, where as soon as the drug is stopped, the gains that were achieved dissipate. So that's not an option. When you start a patient on any of our anabolics, part of the conversation needs to be, this is not a commitment to agreeing to take one drug. This is a commitment to agreeing to take 2 drugs. So I think I find as a clinician, it's very helpful to have that conversation at the beginning, that this is step 1 of a multi-step process. And that patients need to know that they will need to be selecting another agent at the end of the year. And so looking at our options, sort of what kind of data do we have about the options listed here? So we're answering the question, what is the best follow-up? What should I do after my 12 months of romosozumab? So the frame extension studied romosozumab followed by denosumab with a nice big N, and found that in that first year, going from Romo to DMAB, a 3.5% additional gain in bone density at the spine and 2.5% at the total hip in that first year. The rate of improvement of bone density decline sort of abates in that second year, with about half as much gains in the second year when transitioning from romosozumab to denosumab. The ARCH studied romosozumab to alendronate, again with a really a good N, and found really quite similar numbers to that second year of DMAB. So a little over 1% of the spine and a less than 1% at the hip in their first year on alendronate after completing a year of romosozumab. And then the only one I was able to find looking at zoledronic acid was a smaller study, and it happened to be the second course of romosozumab. And what they found was that using a dose of zoledronic acid after that course of romosozumab, which again was coincidentally not their first one, or incidentally not their first one, found that the bone density was stable at spine and hip for 2 years after a single dose of zoledronic acid at the end of treatment of romosozumab for 12 months. So what's the answer to the question as to what the best follow-up is? Something. Do something. Denosumab seems to maybe have slightly better bone density outcomes, but all of the options seem to potentially work to preserve the gains that would have been achieved in that year.
5 minutes.
Thank you. So what about the other half of the story? So sequencing afterwards is one thing, but our patients don't come to us as a clean slate. And as I said, FRAME and ARCH included these washout periods or included treatment naive patients. So all that data is based on patients that aren't switching from a drug to another drug. So what should we think about patients who are currently taking osteoporosis drugs? And this is I think a little more complicated and nuanced, but I'm trying to think, okay, what do we think on this side of the screen? And so the data we have to look at this, let's start with, like my second patient who was on an oral bisphosphonate. So what are options there? And so the structure study from 2017 is helpful in this regard. This is a study of patients that had at least 3 years of an oral bisphosphonate. And then half of them were switched to romosozumab and half of them were switched to teriparatide. And I think this is a very clinically relevant study, because this is often what we see in clinic as people come to us on oral bisphosphonates and maybe are needing to switch to something else for various reasons. And so what they found in this study was that romosozumab led to gains in the hip, whereas teriparatide did not. So the Romo is the blue line, gains. Teriparatide is flat at the total hip and the femoral neck. And that romosozumab had better, almost twice as much gain at the spine than teriparatide was able to achieve in that year after in these patients had previously been on oral bisphosphonates. But I would note that the raw numbers, the gains seen here in this study are about 25 to 50% less than the gains that were seen in the treatment naive patients. So this suggests that the prior bisphosphonate therapy does dampen the anabolic effect of the romosozumab. And then I think the question came up with this one, what about patients who are on denosumab? Often they're on and they've been on for a while and we have worries about continuing it forever, but we have worries about stopping it. The question is, could we use romosozumab as the drug that follows denosumab? And so this one study is a little bit of data in this regard. And this was looking at when patients had actually had 2 years of romosozumab, then were switched to denosumab for 1 year, and then back to Romo. And there was 167 patients that followed that particular pathway. In the second year, in the second course of romosozumab, so those that had done a year of denosumab and then back to the romosozumab, bone density increased at 2.3% of the spine and was stable at the hip. Authors pointing out that the drug at least successfully counteracted the expected bone loss that is seen in that withdrawal period after halting denosumab. But of course, this is a small number of patients, and it's not clear how this data translates to patients who had been on denosumab for more than a year, which is most of our patients who we would be considering trying to switch them to a different drug. But it is data that we have. And this sort of sums up, this is an abstract that from Felicia Cosman and others that was presented at the American College of Rheumatology, and just sums up visually what we sort of just said, that giving the romosozumab before you do an anti-resorptive, you're going to get better gains, more like that 13% and 7% that we saw in ARCH and FRAME, whereas in structure where oral bisphosphonates were before, or this phase 2 trial where denosumab was before, the preceding, if the patient was recently on an anti-resorptive, you can expect that will diminish the benefits seen in bone density in your romosozumab treatment. So kind of to sum up, obviously people who've been on a reasonable holiday or treatment naive are kind of in the best shape to benefit most from the romosozumab. You still will probably see gains, but not as substantial if you're switching directly from alendronate. I really saw nothing in terms of a last dose of zoledronic acid and how that would impact. If anyone else knows about that, I'd love for people to jump in. And the denosumab seems to basically potentially, at least romosozumab holds bone density stable after denosumab with the limited data that we have. Again, it was a short course of denosumab. And following, it's pretty much your choice with the knowledge that you'll get a little bit more gains in bone density, probably with denosumab, which is generally true whenever you're choosing denosumab over a bisphosphonate. So those are the data as it stands right now. So just to sum up the key points, romosozumab is our newest addition to the fracture prevention toolbox, and it's only our second class of anabolic, and it's uniquely both anabolic and anti-resorptive. Its use is supported by a large randomized controlled trial showing significant gains in bone density and reduced fracture risk, especially vert fractures. The numerically larger numbers of cardiac events in arch and bridge led to the boxed warning, contraindicating use with MI or stroke within one prior year, and caution in those at high risk. There were no difference in any of these adverse events between Romo and placebo in the largest, and ought to have been the study that should have seen this if this was real. It's administered in in-clinic sub-Q injections monthly by times for 12 months. Very usefully, similarly to our other in-office injections, it's covered by Medicare Part B and folks Medicare supplement. So financially, it is often a good option, similar to denosumab and zoledronic acid, where the Part B plan kicks in rather than needing to navigate people's Part D pharmacy benefit. The anabolic effect is dampened by prior recent bisphosphonate use or prior denosumab. The effect will be lost unless followed by an anti-resorptive, and further nuances of sequencing and duration of therapy before and after are still being elucidated, but we have a reasonable amount of data to get started, and it's a really nice thing to have this new tool available to us. So I'm happy to take questions or comments, or if anyone has things that they would like to contribute to us all learning more about this new drug.
Excellent talk. Thank you very much. Moving into the Q&A, I have a question that I need to get to here. I cannot imagine when I would prescribe Evenity. It's tough to get past the boxed "this drug may kill you" warning for a disease that is essentially preventative medicine in terms of a fracture prevention and where safe medications are available. When the age of our patients, someone is bound to die with an MI. How do you choose patients or justify the use of this drug under these circumstances?
Well, yeah, I mean, I think that with all of our osteoporosis drugs, sort of weighing risk and benefit has been important. And it's even more difficult when the risk is unclear. Like the data suggesting that the data underpinning this boxed warning is unclear. And we just recently navigated 15 years of a boxed warning saying this causes a very, very scary cancer, and used that drug all that time until it finally sorted out that wasn't probably even the case. I think that it's always weighing in the risks of the risks of osteoporosis and the mortality risk of osteoporosis as well. I use it, a medium amount. It's certainly something I do in talking to the patients. But I would say that it's having another option to improve bone density in patients who are very high risk, and particularly having an option that people can afford, because the barriers to the use of the PTH analogs in cost has been challenging. It has been useful, but it has its limits, a limited sort of appropriate patient match.
Okay, I have a couple of comments in relation to that question also. One is that PTH analogs appear not to work as well in patients who do not bear weight. Romo is a good anabolic in this setting, and those with radiation therapy.
I agree that the non-weight bearing group has really not benefited from from the PTH analogs, and as someone who actually has some fair interest in the bone health of those with significant developmental disabilities, and which this is often the case, having something that might work better in a population such as that, I think is really important. So I'm hoping to see more. I'm hoping to see this is a more beneficial option for that group.
Okay. We frequently use PTH analogs after bisphosphonates. Some have speculated that the decrease in HIP BMD may be related to replacing older, highly mineralized bone with newer, structurally better bone. Your thoughts?
I'm sorry. My thoughts about whether that's a plausible theory.
Yes.
And yeah, I too have heard that that supposition, and certainly it seems plausible.
Okay, excellent. That addresses all of our questions.